is a graduate from Andhra Medical College in 1988 and subsequently came to the East Coast. Came to the East Coast and did her internal medicine training at the Robert Wood Johnson School of Medicine Hospital in New Jersey. That led her to her cardiology fellowship at St. Louis University and Washington University in St. Louis, which is one of the major research centers in the United States. Subsequently, she established her practice here in the South Bay and most recently became a faculty member at Stanford and joined our organization. She is actually a general cardiologist with great interest in nuclear medicine. Nuclear medicine is one of the major diagnostic tools that are used to evaluate coronary artery insufficiency. And she's also a leader in development of remote patient monitoring using digital technologies. So I'm actually looking forward to listen to her presentation and her approach of evaluating risk factors for coronary artery insufficiency and her management of those conditions. So thank you very much for joining us, Dr. Chirala.
Thank you.
Dr. Chirala, you may share your slides now.
Okay. Is that good?
Yes, looks good.
Excellent colors.
Yes, I'm sorry.
Go ahead.
Dr. Molina, thank you, Ashish and the South Asian Heart Center for giving me this opportunity and work to educate some of the public on a very important topic that South Asian Heart Center has been pouring its strength and heart for the decades, for close to 2 decades. And I'm not only happy to be here, but really happy to give some insights onto this very dangerous, deadly disease that attacks South Asian, and would like to see how we together can make this not so deadly. So to get started, I want to first go towards prevention. Prevention and preventive physicians and cardiologists are equally important to invasive interventionalists, because when the prevention is there, then there is less of procedures and surgery that's needed for patients. So I am a huge proponent for prevention, because together again, if we make a huge commitment for prevention of heart disease, then we will make sure that it is not the #1 killer in the world, in India and everywhere. So early detection is a huge need for this prevention, and with adequate changes and medications, not only can this deadly heart disease be halted or slowed or even regressed. And that is what I would like to delve into today. So cardiovascular disease or heart disease, it's a broad term. And I want to first actually tell, what exactly it includes. It includes a lot of diseases. The vascular part is we have vascular structures from head to toe. So we have the coronary artery disease, that is the arteries in the heart. We have the cerebrovascular disease, that's all the arteries in the brain and related issues. We have the peripheral vascular disease, that's related to the upper and lower extremities. And then we have the aorta, the main artery, that can get into trouble with either aneurysms or plaque inside the main arteries. So all together, we have what we call the cardiovascular disease. which is highly prevalent, most prevalent everywhere in all countries. So to get into a little bit of the actual numbers, I would like to compare and contrast globally versus South Asian descent, and see first who we are, what we are. Only if we know who we are and what we are, then we will actually try to make a change and take care of ourselves. So heart disease, cardiovascular disease is the #1 cause of death globally, everywhere. Annually, a lot of deaths that happen, 17.7 million every year. Every 3 seconds, we lose a person to cardiovascular disease. And it causes, as you can see, every 33 seconds, lot of morbidity, mortality, and of course, economic losses. But the difference in the South Asian population is quite grim. This is not a star for us. It is not a star to be on the top of the list for heart disease. And some of the stark contrasts are the early age of onset. South Asians are riddled with heart disease almost 10 years in advance. So they're quite young when they get it. The overall incidence is more than the global incidence. And when it strikes very quickly without warning, not much symptoms. It progresses rapidly, and there is more death in the South Asians compared to the global world. There's certain states that are higher risk. As you can see, friends in Kerala, Punjab, Tamil Nadu, and Andhra. And what is the main crux? Of course, I'm going to go into this more detail, but all of this is related to higher incidence of what we call metabolic syndrome, diabetes, hypertension, and smoking. So that is the grim truth about the extensiveness of heart disease in the South Asian population. I would like to go through a few and talk about it. You know, in the past, maybe not so much now, it was always heart disease is a man's disease. Most of the studies in the cardiology world were done initially using recruiting mainly men. So we have a paucity for women data, but that's just a myth. Actually, I was looking this up. 60 million women in the country have some sort of heart disease, It's the leading cause of death in women. 1 in every 5 is from heart disease. More than all the cancers combined together. But again, the sad truth is only little over half of women recognize this, that it's heart disease that's they're going to succumb to. And women not only have an excess of heart disease, they also have a greater death rate and a worse prognosis when they actually have the cardiac event. So I want to dispel that myth that heart disease is a man's disease. Another myth: if you're thin, you're not at risk. So South Asians usually historically are less in weight compared to other ethnicities, especially the Western world. But that does not mean that they are healthy. They are what we call skinny fat. And as you can see, both the gentlemen are 80 years old, but it's the distribution of the fat, the lack of the muscle, the distribution of the fat, carrying the fat around the abdomen, what we call the apple frame, very dangerous, because the skinny fat people, they may look healthy and fit, but they have a lot of dangerous markers inside them, metabolic markers like diabetes, blood pressure, cholesterol, which are the main cornerstones for heart disease. And so that myth also needs to be dispelled. What is the cause for being skinny fat? It's usually boils down to your diet and exercise, lack of exercise, what you eat and what you don't exercise. So never excuse yourself saying, I'm thin, I'm not going to get heart disease. Going through some basic risk factors for heart disease, cardiovascular disease, I would like to break it up into something that's easily understood, like non-modifiable. It's just you. There's nothing, it's genetic, it's passed on to you, and it's you, basically, how old you are. The older you are, the higher the risk. Males higher than females. Family history, the genes passed on to you. And overall, being just a South Asian is actually a risk factor. And it's called an enhanced risk factor now. So when we calculate the risk factors, we will see that if you have a South Asian ancestry or descent, then you get an extra point for that. The major health conditions, the 4 cornerstone pillars: blood pressure, diabetes, cholesterol, and what we call chronic kidney disease. Very much in tune with heart disease, all of these conditions. And then the last is what you are about, your personality, what you do day to day. Your addiction to cigarette smoking and alcohol puts you at risk. What you eat and how little you exercise puts you at risk. Your weight and other social factors. So would like everybody to look at these and see that the maximum prevention can not be done in the non-modifiable. Really, nothing can be done there. But in the lifestyle factors for the population that you can take care of, and with the help of your physicians and the health conditions. I want to delve more into the main culprits: the diabetes, cholesterol, hypertension, and smoking. So more in terms for the South Asians, diabetes, if you have diabetes, your risk of getting heart disease is double, triple, very much. In the diabetics mainly die from heart disease. So we keep telling them it's not the kidney disease that's going to, or the eye or anything else with the diabetes. When you have diabetes, you get cardiovascular disease, and that is usually responsible for death. Staggering numbers: 1 in 3 have pre-diabetes. Hypertension: 1 in 3. 1 in 3 have high blood pressure. It's largest number of deaths responsible with hypertension, cardiovascular, heart attack, strokes. And the sad part is actually only 40 to 50% of all patients with hypertension have well-controlled blood pressures right now. And of course, we have cholesterol, very common risk factor. The difference in the South Asian population is the kind of cholesterol panel or the lipid panel that we have. Very typical, with low protection from the good cholesterol, lots of high cholesterol, LDL levels, and very high triglycerides. This puts us at a higher risk. Smoking have twice the risk of heart disease, premature heart disease and death, and also the secondhand smokers. We shouldn't forget them. So how do we start? I always feel that if you're prepared, it's not only in your health, but everything, then you are a winner. And the same thing you got to see for your health. You understand your risk. Let us all see how we can understand our risk. Once we understand our risk, then you have an empowered patient. And then you will learn what you have to do to decrease your risk. So we have many ways to assess risk, many scores, many things that cardiologists and physicians sit in front of patients and calculate their risk. And some of the main calculators what we use are your age, your race. Like I said, South Asian descent, it's a risk. The blood pressure, cholesterol, diabetes, family history, smoking, all of these ones. The most commonly used is the ASCVD score or the pooled cohort. Previously, we had Framingham risk scores, and but that didn't do justice to a lot of populations. Even the most commonly used ASCVD score does not justify for our South Asian populations. It does not take into account many of the issues that we deal with, especially our family history. So it underscores us. But that's what we have that right now, that's widely used, all over. So we got to just at least start with that. And then we do what we call risk enhancers. So this is the ASCVD risk calculator. It's usually done in patients that are between 40 to 80, 79 years old. It's really, you don't need to calculate a person's risk if they already had a heart attack or a stroke or bypass or a stent. But otherwise, it is very important when you have a patient in front of you with any risk factors or just South Asian descent, you sit down and you calculate the ASCVD score and see where you are. Because this helps us not only understanding the risk, but also it impacts therapy. And what goes into this risk calculation? Your age, the gender, the race, your total cholesterol, the good cholesterol, your blood pressure, or that particular day that you come in to see the doctor, systolic, diastolic, whether you're on medications for blood pressure, you're diabetic, or you're a smoker. So you take these 10 valuable parameters and you get a score. And then you look at your score. What does that mean? So if your score is less than 5%, then that's good. It's low score. Then you have the two borderline and intermediate, that's between 5 and 7.4, and between 7.5 and almost 20%. That's the intermediate. High is more than 20%. So again, this, as I mentioned, it underestimates in the South Asians because it does not consider the family history, which is very crucial for us. But these are important because, and I will go through the next slide, why it's important. When you get your score, then you're going to ask the doctor, what does this mean? What is 5%? What is 10%? I'm 25%. What does that mean? So then we look at all the guidelines that we have, and then we make a recommendation. We make a recommendation about medications, your lifestyle, and, of course, give you the very much needed advice about having to stop smoking if your risk is high. So this is essentially the guidelines. I know it's a very busy slide, but it's very important because this is exactly what the doctors will do when we calculate an ASCVD score, which, like I said, every patient should get. So when you get your score, then in our minds, we quickly place you where you are, whether you're low risk, borderline, intermediate, or high risk. I want to highlight on the right-hand side this, when your LDL is more than 190, you do not need to put them through an ASCVD score. And because they already need a high dose statin, that's called familial hyperlipidemia. And similarly, if you're diabetic and your age is more in the 40 to 75, your score is going to be very high. You automatically will need treatment. So these are some of the things that we can, we don't need to if you already have a familial hyperlipidemia. And the other ones are very low risk, very young people, or very old, over 80, what do we do? And those you look at other risk enhancers. So when you get your number, your ASCVD score, whether it's 5, 10, 15, 20, we will risk stratify you and see if you are low risk. If it's less than 5%, then that is truly a good sign, because all you need is you work on your lifestyle changes to make sure you don't creep up into the borderline or high risk. And the other end, on the right side, if you're high risk, we know exactly what to do. If you're more than 20%, we know that you absolutely need to get started on a discussion about high dose intensity statins. It's this middle part, the borderline and the intermediate risk. So that's where the middle-aged and not so middle-aged people fall under. And then we need to further evaluate these patients to see, do we really put a 41-year-old or a 42-year-old on statins for the rest of his life? What else can I do to see if he's really at risk? And then we have what we call ASCVD risk enhancers on the left-hand side. They enhance your risk. So if you say, oh, I'm borderline risk or intermediate risk, but I have a really strong family history, or you have kidney disease, or what we call metabolic syndrome, and women, if they have something called premature menopause, or if they have had blood pressure or diabetes during pregnancy, some of the inflammatory disease, and of course, here we go, South Asian ancestry. So if you have these risk enhancers, or if you go in and do further biomarkers like lipoprotein A level or this ABI or ApoB levels, if any of these will help you tell the patient you're at borderline risk, but because you have these other risk enhancers, I really think that you will benefit early on from taking care of this cholesterol, which is a little high. And then the patient is more inclined to listen. So this is what we do, just on a very basic. I mean, there's really nothing to this. It is available on the apps. Is many apps. You can do it yourself as many times as you want, and be prepared, because if you do come up with high risk, then you do want to visit your doctor and say, hey, my score is high. What do I do? It is widely available on the internet. Google it or get an app and you can do that. And next I will go into depth. So if you're having risks and your risk is high, then you go to your doctor and you get some routine testing first. What is the routine test? First, a simple blood pressure, fasting cholesterol, screening for diabetes, and ECG, vitamin D levels. And then based on what these come out as, you can have more advanced additional testing, which I will go into detail. And in a cardiologist's office, you will go all the way to even stress testing and echoes if needed. I want to spend a few minutes on what we call as advanced lipid testing. So some of those risk enhancers that I was talking about, it's all comes from this blood test that's called an advanced lipid testing. So we see that some patients are even high risk because of a strong family history. They're young, but they have a strong family history and they have some borderline cholesterol. And we say, hey, we would like to know if your family history is that strong. What do you have right now? So we do this advanced lipid planning testing. which not only gives you the basic lipid profile, but it goes into telling you the kind of LDL particles that you have inside you. Do you have the nice plump pattern A particles that actually don't slip inside the arteries and cause blockage? Or do you have pattern B, which is small, dense LDL particles that easily slip inside the arteries and start clogging at a very young age? You know, when I first started here in the late 90s, I met Dr. Superco. He was running the Berkeley Heart Lab and was a big proponent for the Berkeley Heart Lab testing. And we had tested many South Asians, just alarming numbers of this advanced lipid panel. So because the kind of cholesterol particles that we carry, the ApoB and the type of cholesterol particles are dangerous. And that runs in families. Even the good cholesterol, the HDL-C level, the good cholesterol protects you. But the South Asians have this kind of good cholesterol that's actually not very protective. So you can have a good HDL, my HDL is 65 or 70, but it may not be. When you do the advanced lipid testing panel, you will know that it is not the right kind. And that's also a genetic trait. So because these HDL particles are very small, they don't work well. There is another very atherogenic protein, a particle called lipoprotein A. Very prevalent in the South Asian population. Almost 25% of us or more have lipoprotein A levels. And this is truly genetic because they have found this in the cord blood. When you're born, they've done samples from the umbilical cord and have found lipoprotein A levels. So it's expressed very early in life. So it's never too early to know where you are. Do you really have this dangerous lipoprotein A level? Why? Because it doubles your risk of having heart disease. It doubles. And we can do something about it. Remember, you can halt, slow down, regress your heart disease. Yes, we can. So high lipoprotein A levels over 75, 100, 200, we've seen all numbers. And, family history is usually there. We don't need to wait until an event happens. So we early on screen these patients. And now in this new age, we have fantastic treatments for these lipoprotein and cholesterol. We had our traditional statins for many decades, and now we are on this new injectable cholesterol medications called PCSK9 inhibitor agents, which are now many studies to prove that they actually will help the lipoprotein A levels come down. Statins really don't decrease the lipoprotein A levels, but you're still required to keep your LDL low. But the new PCSK9 inhibitor agents do. So there's a lot of data and studies that are now going on to help lower this dangerous lipoprotein level. So switching to another favorite of South Asian Heart Center and most cardiologists. This is the new kid on the block. It's not so new, actually. It's been there for a long time, but really never got popularity until, quite recently. Coronary calcium score. This, what we call CACS testing, coronary artery calcification. It is a more for you, personalized, more functional form of testing. So in your coronary arteries, you're just supposed to have blood flowing in them. They're pipes, just blood flow. But then when you have all these atherogenic particles and all these risk factors, then in the intimate, you'll start getting plaque. And as the plaque starts building, the white plaque, it starts getting calcified. More and more old plaque gets calcified. Plaque, you cannot really see on CT scans, but old plaque, you can. And the calcium, it picks up the calcium with very high accuracy and gives a number. So this CT scan is only about 10 minutes, no IV, very simple. And in each of your coronary arteries and the branches, it gives a number. And the best is 0. And it tells you where you are. And there's a lot of prognostic information you get from this simple coronary calcium score. A lot of studies to show where you are depending on your value. So this is when you are sitting with that medium or intermediate risk, borderline risk, this is the test that we go to say, yes, you need some help. And so the coronary calcium score, your results come out as 0. Very good. It's a very good negative predictive value to say you have 0. You have no evidence of any calcium. And that's a very good sign. Your risk of having an event is quite low in the next year or two. If you have 1 to 10, it's very minimal. 10 to 100 is mild. And of course, 100 to 400 is moderate, and over 400 is severe, extensive. In South Asians, they usually drop this 400 to 300. So now putting it all together, why is this coronary artery calcium score important? So when you first calculate your risk and say, yeah, I'm low risk, I'm okay. I'm high risk, then you have the doctor's attention, you're immediately started on medications. But then if you're in this intermediate risk, what do we do? And you're young, you're really young. What do we do? So then we try to do this coronary calcium score and say, if you truly have a 0, then you really don't need to get started on a statin right away. You can wait. You can recheck it in the next, depending on how risky you are with your family history and other risk factors. In another 2 to 5 years or 3 years or 5 years, you can recheck it and see if your levels are going up. And if your score is not 0, if it is 0, you can wait. You don't need to quickly get started on the statins. But if it's more than 0, then you have risk factors and you already started the process. So you get started on treatment. So it basically reclassifies you up or down so that you can get the appropriate treatment at the right time. And that's the value it brings. So it has come out as the most predictive single risk marker in patients who have no symptoms. Remember, we are not going to take a patient who's having chest pain and say, let's go get your coronary calcium score. This is only for patients who are stable, who want to understand their risk, who have no symptoms. Then it'll give you a lot more data about what you can achieve by this very cost-effective, low radiation, cost-effective, test that we can do. We also have the Masala trial. Is the mediators of, in the South Asian population, the atherogenic and so in that, basically this is a trial that's going on in for a few years, actually. And they're trying to find out what is the reason. Why do South Asians have a higher risk? What is the actual reason? And so they started this trial and they basically came up to a few conclusions that we only are 25% of the world's population, but carry the burden of 60% of the world's heart disease. So basically keep making it like an epidemic. And into more in-depth testing of these patients, it has come to know that one of the reasons is the South Asians carry a lot of fat in the wrong place. Remember I said the skinny fat, the apple frame where you have fat around the belly, that fat is actually goes more into the liver and the heart, and that's more atherogenic and gives an increased risk of having heart disease. So South Asians have that. And also the diabetes by itself, it's almost 3 to 4 times more are diabetes incidence. Also, the coronary calcium score, more than any ethnic group, it's much higher. So this is still ongoing, and they keep releasing information, and it's always a pleasure to listen to them and get more information. A little quiz about why is our Indian population, we are mainly vegetarians. Half the country is like vegetarian. Why do we have such an increase? Is it because of shifting towards the Western dietary habits, processed foods, fast foods, sedentary lifestyle? All of the above? I'm sure you all know it is all of the above. And the Indians who migrate to America, to US, are actually higher risk for having heart disease than the Indians in India. So we have to look very closely how we come in. That's why when we shift very quickly towards the Western dietary habits, more fast foods, processed foods, and we know our lifestyle, so we quickly get the highest risk of heart disease, more than Indians in India. Also same in urban. In India, the urban cities have a lot more heart disease than the rural cities and rural state, cities. So what are these dietary habits? Like I said, half of them are Indians, are vegetarians, but it's because of the carbohydrates. It's a high carbohydrate consumption. And the fat that we consume is a high fat dairy, which, the ghee, the malai, the khoa, in almost everyday meal. So it's not plant-based, it's high fat dairy. Another common use in reusing your cooking oil. It transforms the fats into the trans fatty acids, which is not good. Surprisingly, we eat now less fresh fruit and vegetables. Of course, there's also a social component of economics and affording. Another question everybody asks: alcohol, is it good or bad for you? It's actually not good. Many issues with alcohol. It can not only lead to high blood pressure, increased risk for heart failure and stroke. So, people think, oh, I just have 1 or 2 glasses. We share a bottle of wine. No, that's moderate. That's moderate drinking. Moderate drinking, what is that? For a woman, it's 1 drink per day. That's it. Anything more than 1 drink is moderate. It's not mild. 1 or 2 for men. But what is that 1 drink? It's 1 beer or only 4 ounces of wine, not a glass. So when the patients say, I have 1 glass of wine with, that's a little too much. And the other problems we consistently see is in our offices, we put most patients on statins. Statins and alcohol, very hard on your liver, very hard. So overall, not good. Lifestyle changes. Everybody knows it, but finds it difficult to actually follow through a heart healthy diet. Exercise, minimum 150 minutes per week or 75 minutes of aerobic exercise. Limit your alcohol. Sleep, very important. Stress, smoking. And again, just going through some of these heart healthy diets is, again, the Indians have it. We have all these whole grains that's available, but we're going towards the processed grains, going back towards the whole grains, fruits and vegetables, eating more nuts and seeds, plant-based. everything should go towards your protein, your fat, your dairy, all should go towards plant-based now. That's the song we are singing every day, everywhere, and it's picking up really quickly everywhere, as you can all see in our grocery stores, in our restaurants. It's really wondrous to go see all the healthy plant-based meals and opportunities we have to buy. So I really have to give credit to the South Asian Heart Center for their aim to prevent and stop D programs, because, you know, as a cardiologist, I get only so many minutes in front of a patient, and by the time I discuss the risk factors and the treatment and you know, I am, and you know, really explain in detail, I don't have time to discuss about their lifestyle. I just don't have. But that is the key. That is actually a pivotal in the patient's management. It's the along with the medications, you need the lifestyle programs, the lifestyle change program, very important, very important. So I collaborate with South Asian Heart Center to tell my patients, here, you're diabetic or you're pre-diabetic. They have a fantastic culturally tailored program where you get support, interactive sessions, you have these life coaches. They're really good. Patients love them. They feel somebody is with them, you know, to make this change, aim to prevent. They focus more on this meds, the meditation, exercise, diet, and sleep. So kudos to South Asian, you know, Heart Center. They're doing a great job in this. Medical prevention. And so this goes towards your doctor. And this is not a forum to discuss which kind of blood pressure medications, which kind of diabetes medications, or which kind of cholesterol medications that you will need. But if you are at risk, you will need something. And it's not just the cholesterol. Blood pressure, very modifiable risk factors. So now, during the pandemic came out remote patient monitoring. We now have devices that we give patients who monitor their diabetes or blood pressures or weights at home every day, and it connects those numbers to the doctor instantly. Right away, the doctor can see what it is. So, and then there is a support system in the background, the clinical services, who is going through all the numbers to see who falls out, whose blood pressure is too high, too low, and they reach out to the patient. And if it's not able to be controlled, they reach out to the doctor. So in between appointments, because of remote patient monitoring, now you're connected to patients. Now you're able to get very quickly great control of these dangerous byproducts, blood pressure, cholesterol, diabetes, very quickly, because you have now empowered your patient with this device that connects the patient. The patient feels that he's being looked at. The doctor is with him. The nurses are with him. And when he starts monitoring the blood pressures regularly and knows that, oh, my blood pressure is too high today. What did I eat? And then they start thinking, maybe I shouldn't be eating this. So I have over 500 patients that I collected data for the last 3 years, and I was able to do lifestyle interventions using the remote patient monitoring on these patients. And we had questionnaires, and patients responded so positively that I put it in an abstract and will be going and presenting to the American College of Cardiology next week. It was outstanding that patients felt so empowered and so connected to the doctors that they're willing to make the changes. And so the medical interventions, of course, happens with the help of your physicians, with medications first, who gets aspirin, who doesn't get aspirin, and then advanced testing, like there's the coronary CT angiogram, regular cardiac catheterization is an invasive test where you go in with catheters inside your heart. But we also now have coronary CT angiogram, which is less invasive. It's just an IV, and it gives you a value of information, a lot of prognosis, very good for the South Asians because we present with different kind of symptoms and present late, and it categorizes your plaque. It tells you whether your plaque is the dangerous kind of plaque, the morphology, the extent of the plaque. So very valuable for patients who are sitting in that borderline and are having some symptoms, but you really don't want to send them for the angiogram. You can do a coronary CT angiogram. And of course, if they fall out on all of these, then they go get their stents or bypass. And well, thank you all. Basically, it's to empower the men and women to really understand what you have. And going back to saying prevention is the cure, prevention is all, understanding is all, empowerment is needed. And then we can cut down this pandemic, epidemic, heart disease for the South Asians. Thank you.
Thank you, Dr. Chirala, for the wonderful talk and emphasizing on prevention. We've got tons of questions, and I think we've got about 30 minutes.